You know, we all get on this journey, and you're joining this journey of airway issues, and dentistry is under a big change as far as the thinking and the paradigm shift of how you treatment plan. And of course, I went to dental school here, and the title of my presentation is Dentistry's Impact on the Airway and Sleep. Actually, I did this presentation, I modified it for today's talk in reference to HealthyStart, and I'll show you the case that we got started. But I did a presentation to a group of sleep physicians and sleep technicians in Austin back in October through the Texas Society of Sleep Professionals. That's a good organization you should look at joining. And it's actually going to be in October here in Galveston. I'm not sure the date, but you have to look. But they're always looking at incorporating dentists and the dental professionals into this, as is already known, because CPAP is one option. And it is the gold standard, but you know, when you're talking about kids and even in adults, you know, the percentage of failure is high. And I'm going to go into that some. And I'm just curious in the audience, I know there's a doctor I talked to, Dr. Juarez, she's involved with dental sleep medicine. I'm not sure who else in the room is doing like oral appliances for adults. Yes, and are any of y'all? Okay, good. So some of the terminology that I'll use, you know, if you're not familiar, feel free to stop, ask questions, because some of it is medical language, and so if you're not familiar with it, it can kind of be like, what does that mean, right? So, all right, so let's get started. Let me see if this works. Okay. So as I told you, I went to dental school here in Houston. Of course, it used to be called the dental branch. Now they changed the name. I'm not sure why, but then it's almost 12 years next month that I graduated. I did an AGD residency in San Antonio and helped me expand my treatment to patients. And then as I got involved in opening my own practice, I did a dental sleep medicine mini residency at Tufts University in Boston. Great program for any of those who haven't, you know, that would like to look into that. And then right now I'm currently finishing an oral facial pain program at LSU School of Dentistry that deals with airway issues, TMD, and sleep, because there's a correlation there. Again, this is my practice in the building right there. I'm in a condo with a bunch of other professional dentists there, pediatric dentists, orthodontists, a prosthodontist. Right above me there's a periodontist, and then there's a ophthalmologist and optometrist. And right here, you don't see the sign up there, it's just an older picture. There's a Mighty Kids Therapy, which is a speech therapy, which is a great, we haven't really connected. I've been kind of talking to them because of our busy schedules. And if you're wondering where I got the name of my office, Paloma Vista came from simply the neighborhoods that are around me. Paloma, Lake, Terra Vista, I live in this neighborhood, so that's really where that came from. Of course, you mentioned it in Round Rock. I don't know if you guys are familiar, probably been there, the Austin area. And that's where the town got its name, if you're not aware. Yeah, the Chisholm Trail, famous Chisholm Trail. And then, of course, my wife, she's a dental hygienist, and she's been instrumental in helping me get going with the practice and all that. So it's a team effort. And again, you know, I'm sure as many of you are members of these organizations, ADA, TDA, of course, Capital Area Dental Society is the local society in our area. But these are great organizations I highlighted in yellow that if you're not a member or would like to get some more information, they're great. Especially American Academy of Physiologic Medicine and Dentistry. They really talk a lot about the airway, kids, and you know, so that's, I did this timeline here to kind of give a, if you're not familiar with where this all started, right? And the interesting thing is that all this stuff we're talking about in medicine, it doesn't go back very far. You know, 1953, REM disorders were discovered. Dr. Dement, the father of sleep medicine, still living. And 1966, you can see the sleep apnea was discovered. And then, of course, 1970, the first sleep lab opened in Stanford, you know, in California. And so that's where the group I was speaking to, the sleep technicians, that's where their profession was born, so it's not that old. 1974, PSGs, polysomnogram, that's an in-lab sleep study. And then, of course, you know about CPAPs in the 80s. They were introduced as a method of blowing open the airway. And then, of course, Christian Guilleminault, who's a big name out there in the medical literature. He's a neurologist. And by the way, let me back up. Dr. Dement is a psychiatrist, and so he was studying sleep and all that, how the impact of all that, and then he brought in the neurologist from France, Dr. Guilleminault, and he added a lot to that. And so the term upper airway resistance syndrome is something that's not talked about a lot. Of course, we talk a lot about sleep disorder breathing, but that's something that is out there, and he discovered that in kids and how they were breathing and not necessarily apnea, and of course also in adults. And then the other recent developments, Abram Gold is a physician out of Stony Brook, New York, that basically has got a lot of good medical literature out there on airflow limitation, which is basically breathing while you're sleeping and not getting good oxygen and all that. And so anyway, so it's a busy slide, kind of a lot of stuff changing. And the interesting thing in 2014, as you can see there, upper airway resistance is not a recognized discrete entity for the ICSD-3. So that's a little controversial there because it's recognized clinically, but sometimes it's just not diagnosed. And I'm sure you, with the medical billing stuff, can add some insight into that later. But the timeline keeps going. And what's interesting, last year, the ADA, American Dental Association, finally says, okay, let's make a policy to see where does dentistry fit in all this stuff, right? You know, because oral appliances come out in the 80s. The American Academy of Dental Sleep Medicine's really grown and made that to a great organization to really help execute oral appliance therapy as an alternative to CPAP. But then the ADA never really said anything about it, and dentists are out there doing this, and so, you know, and that's still out there, and I'll show you what the statement is later on here. So when we talk about airflow limitations, you know, you look at the, I like this chart because it's pretty simplified how it shows the air here, the arrows coming this way, and the thing about that is that, you know, we talked a lot about hypopneas, apneas, but airflow limitations, you get that slight little drop in oxygen and airflow, that can create a lot of problems. And perhaps a lot of the stuff we're seeing in the kids, you know, and I'll show you this quick little video. I don't know if you guys seen this. This is from ResMed, but it talks about airflow limitation, kind of give you an idea. It's a volume?
Flow limitation. What is really happening? For those who have SDB, the muscles in the upper airway begin to relax during sleep, and the tongue and soft palate move closer to the back of the airway. This usually occurs if you are lying on your back or side due to the force of gravity. As the airway gradually narrows, it limits the rate at which air can pass through. We call this flow limitation. The airflow curve now has a characteristic chair-like shape. The middle of the curve looks flatter than it does for normal breathing. The flow at this point is being limited by the restricted airway. As these breathing effort traces show, our model is working harder to breathe. Despite the flow limitation, the sounds of breathing are still fairly normal. From breath to breath, as flow limitation continues, the oxygen level in the blood remains quite steady, and the heart rate remains fairly stable. At some point, the increased work of breathing against flow limitation may lead to an arousal. An arousal is a disturbance in the sleep cycle. This may be accompanied by some movement. There is a visible increase in brainwave activity and heart rate. Each arousal has a powerful effect on your body. On arousal, our model quickly takes a few deep breaths. As muscle tone returns to the tongue and soft palate, the airway opens. The airflow trace returns to the normal bell shape, although an amplified one. This flow limitation arousal sequence may occur several times every hour. Although there may not be much change in the sounds of your breathing, your partner may notice you tossing and turning restlessly. You may wake up feeling tired. The effect on your body is strong enough to disturb your sleep and prevent you from getting the real rest you need in order to be healthy.
So basically that kind of gives you, in the next part of that, I'm not going to show it to you, this talks about snoring, the vibration and all that, but that airflow limitation is something that Abram Gold is introduced to the medical community as far as, should we be looking at this at a more subtle level? Because the fact is that as a practicing dentist in the clinic, I'm sure most of you guys see a lot of wear on teeth and people with TMD issues, or people who seem stressed out and they're like saying, well, I don't sleep very well. They go get a full PSG done or a home sleep test. It may come back and it shows, well, you don't have any apnea, sorry, can't help you. But then they continue to get worse and things get worse. And that's kind of where, as a clinician, I feel obligated to do something, right? And so that's really where I think dentistry has and it's developing into, I talked about arousals, right? And so the arousals stimulate the brain. And something that is interesting in the medical literature is the HPA axis, the hypothalamus pituitary adrenal gland axis, and how that gets activated. And basically, bottom line, it releases stress hormone, epinephrine, and of course in our realm, we see the possibility where this sympathetic drive triggers the bruxing and clenching and trying to get rid of that, even during the day, like daytime bruxism. I'll talk about that a little bit more. Again, Abram's work, somatic arousals reflecting the sympathetic nervous system component of the stress response. This is recent medical literature from last year. Sleepiness and fatigue among URRS patients are correlated with their level of somatic arousals and suggest that the same is true of obstructive sleep apnea, hypopnea patients. In patients with sleep disorder breathing, there is a strong association between the level of somatic arousals and the presence of stress-related disorders like somatic syndromes, anxiety, and insomnia. I'll explain to you in a minute what somatic syndromes are. So again, these are just papers, literature, just to kind of show where I got all this information. And interestingly on this, how it goes back to HealthyStart, and the new insights on the pathophysiology, that's what this paper's talking about, the inspiratory flow limitations during sleep. What they found was that there was a nasal and a palatal anatomical abnormality in this. And so you can see where HealthyStart, again, is a great tool to get kids early so that their craniofacial development, perhaps they never get these problems. And of course, ideally catching them younger is the best. And what I tell you that from experience, and I'm sure you guys do know that, treating these patients that already have the sleep disorders or the sleep apnea, it's a little more challenging because now you got to manage the disease rather than prevent it. And as dentists, we like to prevent stuff, especially the hygiene, right? Floss, use your fluoride, brush your teeth, and then of course as dentists, we're talking about sealants, and yet when it comes to this, when patients are starting to get on those subtleties or have those signs, you kind of wonder, well, what could I do for them? I'm just going to let them get sicker until they get apnea and treat them, or what can I do, right? Dr. Guimeno went to Brazil. They did this big study, and they were wondering, well, how common is airflow limitation in the population? And the reason they went to Brazil, the huge population, their system set up to allow a lot of these studies and funded through the government. And so anyways, what they found was that if it occurs more than 30% of the night, that is a concern. Now, I will tell you that most sleep labs don't look at that very subtle level. So that's the dilemma right now, or the challenge, I should say. And so again, this is new stuff that's out there that is progressively moving in the realms of sleep medicine. Again, the role of flow limitation and its diagnostics. Basically, I highlighted here the subject with flow limitation demonstrate encephalogram changes and clinical symptoms indicating sleep fragmentation, again, the brain activation of that HPA axis. Symptoms and signs of upper airway resistance. There's a link to functional somatic syndromes, and I'll show you what those are in a minute. And again, here's some just more papers on this stuff. I kind of dug up everything I could on this to kind of get to the point here. So, the functional somatic syndromes, anxiety disorders, and upper airway matter of paradigm shifts. Finally, building upon a existing paradigm of neural sensitization, sleep disorder breathing is linked to functional somatic syndromes and anxiety disorders to chronic activation, there you go, the HPA axis. So the question becomes, when you start activating the HP axis as a little kid with sleep disorders, we talked about ADD, ADHD. Could that be a link? I haven't seen a lot of papers, but it's interesting to see that with the adults, they're finding that to be an issue. And of course, that leads to a lot of these anxiety issues, depression that we know that are linked to sleep disorder breathing. Another challenge, and this is in the journal, Barry Krakoff of New Mexico, University of New Mexico, was just talking about, some of these terms, RIRAs, airflow limitations, upper airway resistance, and basically right there in green where I highlighted, he just talks about how a majority of clinicians and researchers may have been unaware or unconvinced of its clinical relevance. In other words, that's not really, we don't really care about that too much at this point. Again, why is that? Because on a PSG, you're not going to see DSATs going below 90%. The AHI to diagnose the sleep apnea is probably going to be below 5, but the RDI will be, that stands for respiratory disturbances, will be very elevated, so it shows some fragmentation of the sleep. And again, RIRAs aren't scored all the time in the sleep labs, so not all sleep labs are created equal. We're looking at that. Here's some more quotes from Dr. Goad. I'm quite convinced that when the work is done, it will demonstrate that inspiratory flow limitations during sleep are the unrecognized cause of much human suffering. Inspiratory flow limitations during sleep plays a role in development of functional somatic syndromes and anxiety disorders and manifests as chronic stress and adrenal fatigue. Gold's thesis states among patients with functional somatic syndromes and anxiety disorders, IFL serves as a chronic activation of the HPA axis, which causes symptoms of the functional somatic syndromes and anxiety disorders that show up in chronic stress. Again, here's a list of these functional somatic syndromes. You can see that I highlighted two of those that are dental related, that a lot of times patients come to see us for migraine, headaches, TMD issues, and anxiety disorders. You'll see that on medical histories on the intake, fibromyalgia, chronic fatigue syndrome, and a lot of females are, at least in my practice, I see a lot of that going on, and so I'm like, how can I help them, right? So I got this to show you, and I asked the question, is this still true in 2017? This is a note talking about the spectrum of sleep disorder breathing, from normal breathing all the way to severe apnea. And of course you see that this was printed, and I just put it up there because I thought it was interesting that they considered snoring not being a disease, not to have upper airway. But even as I move forward, I'll show you in a minute, but Dr. Paleo is a sleep physician, pediatric sleep doctor out of Stanford, and that was his quote: sleeping should be silent, no such thing as normal snoring, should not be snoring at all, right? So if that's true, then that's the new textbook that just came out this year, Principles and Practices of Sleep Medicine, and it talks about recent evidence shows that simple snoring carries consequences of cognitive impairment, suggesting that benign primary snoring should be treated as a disease. The incidence of snoring is much higher than the incidence of OSA, and snoring is now recognized as an abnormality in children. So this is the textbook of sleep medicine by the experts now talking about this. So again, validating what we're doing with HealthyStart even more. It's not just straightening teeth, it is really helping these kids develop to their full potential, and I'll share some more in a minute with you about that. So upper airway resistance, again, not very commonly used. It's got thrown out of the ICD-3 or brought in as a mild form of apnea. And that was a paper that from the Journal of Dental Sleep Medicine that talked about whether it really exists as a disease. And they were saying not really. And so again, you can find papers for everything, right? There's another paper over here that showed that upper airway patients actually have a worse sleep quality, more fatigue, and worse early morning sustained attention compared to a mild OSA. And this diagram right here kind of explains my motivation for getting into what the HealthyStart system, because I've been trained to treat people on the medical recognition of this, and I'm sure many of you, where they have sleep apnea, okay, they have a CPAP, maybe they failed the CPAP, now they need an MAD, great. And again, the Academy of Dental Sleep Medicine has been great to help us get a system to follow, to execute the best care possible to the patient in collaboration with the physician. Now, if you notice where that line is drawn, of course, I just kind of put down the dental recognition of that, where, you know, we see a lot of this. And that's where I think HealthyStart is key. Again, now I have a tool to be able to help the kids before they ever cross this line over here. And so, the thing about that is that this paper here just kind of talks about how craniofacial structures and even heritability of parents that have sleep disorder breathing or sleep apnea, how their kids can even, be at risk for this. And I just kind of wanted to throw this out there again. I'm not trying to be controversial, but there's a lot of politics, a lot of, depending on what you believe on this. But the thing is, I'm just trying to present the information for what it is. And dental sleep medicine or sleep dentistry is a study of mandibular advancement appliances and its impact on the airway, manage the disease, again, manage the disease. I've always say with oral appliance therapy in combination with PAP therapy or in collaboration with a medical team. Of course, the airway is managed only at night when asleep. Now, these are terms that are out there: sleep prosthodontics, airway-centric dentistry, airway-focused dentistry, and it's a different way of looking at things as dentists, study of the airway's impact on the stomatognathing system. In fact, if you look up the definition from the American Dental Association, it doesn't even have the word tooth listed in it. It says we are doctors of the stomatognathing system. But unfortunately, our profession has, we're not known for that, right? We're just like, fix my tooth, pull it out, or do this. I mean, that's part of what we do, but we're more than that. And so, so basically, again, I think HealthyStart fits into that model where we're trying to prevent something from ever happening and get these kids intervene. And again, you have out there a lot of different things going out there, like with myofunctional therapy, orthodontics, and again, even orthodontics is under a paradigm shift. And I'll show you a case of why I'm so passionate about this stuff. But really, the airway is a 24/7 thing, and that's the nice thing with a HealthyStart. If you catch them early, intervene, that airway is going to be impacted to where they're going to be able to breathe better during the day, sleep better at night, and then even eat, because even some kids have trouble swallowing. Their airways are so small they can't even pass food down. Jeff Rouse, a friend of mine in San Antonio, wrote this autonomic nervous system trial in one of the magazines here in Compendium. The classic model of sleep medicine or sleep dentistry are ignoring the vast majority of patients in dental practices with breathing disturbed sleep. The apnea-only approach misses the chronic stress conditions elicited by the autonomic nervous system and the HPA axis activation, while CPAP therapy and mandibular advancement appliances are excellent tools. They both have poor long-term compliance, especially for patients with mild OSA and UARS. So the problem's bigger than apnea. These are just some numbers from the textbook I showed you that talks about, children 2 to 8 years old, peak OSA 1 to 5%. Of course, it increases with obesity. And of course, upper airway resistance is more common, but often not diagnosed. And then men, we tend to succumb to this problem quicker than women. You can see 10% from 30 to 49. As men get older, that increases, of course, and that's true of women. So usually by menopause age, women kind of catch up to the men, and that has something to do with a progesterone hormone believed to help maintain the airway. And again, that's why I think we see a lot of TMD patients who are more women. They're fighting the airway. They're trying to get better sleep. They're just keeping it open. And again, that falls in the realm of dentistry. And then again, that's what I talked about, where the UARS is AHI less than 5, the RIRs are high, but they're not always scored by the sleep lab, and that's true of kids. And by the way, too, and looking at all this information, I didn't realize that sleep medicine for children is really at its infancy. A lot of the application of sleep studies towards kids comes from what we know about adults. Of course, they're different physiologically. So how do you get a sleep study on a kid? I mean, there are centers out there, but in my area, I've gone around and they say, we don't see them until they're 12. And I'm like, wow, okay. So, but I found some great physicians who are helping me with that currently. But again, the point is even when I was doing this presentation with the Texas Society of Sleep Professionals, they had a doctor from Dell's Children's Hospital in Austin who was talking about this, and he says we're still at our infancy stage, and and it's evolving. So that's yet to be seen. So why is the dentist in an ideal position to identify these airway issues? Well, you look at the anatomical, this is a cadaver dissected, and it shows the percentages of the blockages where they are, and of course the velopharynx, up there in that area, behind the tongue and the uvula, that's kind of common areas where these blockages occur. Dr. Hendon, I like this comment there. It says, everything dentists do in their daily practice can influence the airway and physiology of the patient, whether the practitioner knows it or not. And so why is there, here's from that textbook too, dentists are healthcare providers who see more than 70% of persons of all ages at least once a year. So again, we're in an ideal position. And then especially the hygienists, because you guys spend more time with the patients, talking about them with stuff and seeing kind of some of the progression and the wear and tear of the teeth, or the inflammation of the gums and the inflammation of the oral mucosa. So airway impacts everything done in dentistry, how people are breathing, whether it's through their nose or through their mouth, or Gary Caddy's a consultant. He wrote this book, very good short read, The Dentist, America's Next Healthcare Hero. And that's the comments from his book. The mouth is a gateway to total health and wellness. According to his comment, the insurance companies have essentially taken over medicine. As a result, our entire healthcare system has been commandeered by people sitting in buildings who have no medical expertise whatsoever. That's where the unwise part of our predicament comes in. And of course, recently our healthcare trying to change, and that whole debate, and says, I love what he said here, as we stand at the precipice of a massive healthcare overhaul and a complete overturning of the medical establishment as we know it, I see limitless potential. I see a system being turned on its head, and that chaos, I see the opportunity for dentists to rise up, join together, and give the world what it's aching for, total health and wellness. And again, HealthyStart is part of that paradigm there. The tip of the iceberg, we're talking about OSA, snoring, but I'm sure a lot of you practicing dentists see a lot of this stuff in your practice, and the medical history, the fatigue, the reflux, the fibromyalgia, the ADD, the headaches, TMD, the anxiety, the insomnia, UARS, and of course I've been talking about airflow limitations. So we're just scratching the surface. And so I think, again, and I'm excited more than ever to be a dentist, but there's a lot of challenges that we face, and I'm going to talk about some of that. Dr. Stephen Part, ear, nose, and throat physician, sleep physician out of New York City, wrote that great book. If you ever get a chance to read it, Sleep Interrupted. That's what he said. He's not even a dentist. He says at least we should pay more attention to children's dental health, making sure to prevent narrowing of and developing jaw structures. Because, as we already talked about the last day or so. Another non-dentist person, Patrick McCohen, he wrote this book called The Oxygen Advantage. Again, infant and children who breathe through their mouths due to nasal obstruction are likely to develop crooked teeth and a longer face, narrow face, permanently affecting their appearance. Mouth breathing also has a significant impact on the health of the child, including restriction of the lower airways, poor quality of sleep, high stress levels, and lower quality of life. From the medical literature, going back to Givino, of course, there's some validation of using rapid maxillary expanders in combination with adenoid tonsil removal. Of course, that is the first method of treatment for kids to remove their tonsils and adenoids if they're then diagnosed with obstructive sleep apnea. But, my concern always with the palatal expanders too, we talked about that a little bit with a habit corrector, is their tongue posture, where is it? And so I think, again, HealthyStart has a great solution for some of that. Malin potty, these are just 3 studies again that show, practical value, who's at risk. I'm sure you guys are familiar with that. Have somebody open their mouth and you can't see the airway back, they're at a higher risk. The Brazilian Journal of Otolaryngology talked about if somebody has a class 4 Malin potty, and a nasal obstruction, they're at a higher risk, which makes total sense. But then an American study, otolaryngology, talked about, well, maybe there's not enough evidence for that. So, so you can see how this goes back and forth, right? Again, yesterday somebody mentioned the tongue, and, of course, diets, the tongue can get fat. And an interesting thing, sometimes as we even lose weight, the tongue doesn't lose weight anymore, so, and I don't know if you guys observed this in the clinical practice where you take back molars out, or somebody who's lost teeth, their tongue just kind of spreads out, and then you put a partial in or something, and they don't like it, their tongue, so again, airway issues, airway related things. Increased tongue volume and deposition of fat at the base of the tongue in apneic compared to controls, that's what that study looked at, and it's believed that as the tongue gets, bigger, it decreases its function as an upper airway dilator, to breathe better. And so further studies, of course, need to be done on the significance of that, and I'll show you some stuff in a minute about that. And then, of course, this came out last year in one of our journals, and it talked about, again, the airway, the tongue, and the arousals, the fragmented sleep, and the blockage, drop of oxygen, and again, the whole thing here, the whole theme is that this activation of the sympathetic nervous system. It's not good, And so this is one of my patients, and she wanted me to repair those front teeth that were chipping away, and I said, I think you might have a breathing problem at night, and she's like, no, I don't. I sleep elevated, 2 pillows in the back. And I'm like, okay. So I didn't fix those. She finally believed me. I called her doctor. She went and got a sleep study. It turned out to be moderate apneic, and she's on the CPAP. And so she's doing much better. Now her husband came and said, thank you so much. My wife is so much happier, and a very pleasant lady. But now it's interesting how we, in fact, her doctor, and this is not something to brag about me, it's just more of the recognition as a dentist. She says, I don't know how you found or suspected that. And I was like, well, and of course it was hard to explain everything I'm trying to tell you here, but she was just impressed as a dentist we were able to identify the risk and refer. And again, the thing we talked about, is the tongue too large or is the jaw too small? So I believe the jaws are too small, that they're just not growing craniofacially. And again, the validation of HealthyStart to really begin to identify these kids. Myofunctional therapy is out there, and of course, good way also to treat. But there's few and far between. That's becoming more popular. And again, this is just a paper showing the results they get with adults and kids. The percentages are pretty high. When we talk about screening, I'm sure you guys are familiar with these: the Epworth, Stop Bang, the Berlin questionnaire. And then the fatigue severity score is something that I implemented in my practice, especially with some of the women, because a lot of times the women say, well, I feel fine. And when you start talking about fatigue, they're like, okay, now they get their attention. And so, again, Stop Bang, this is very good way to screen, to find out, who's at risk, and for a referral to the sleep physician. Again, this is for adult patients. I'm not talking about kids at this point. And again, another paper that validates that if you have 3 or more yeses, you would have a pretty high risk, and I've found that to be true clinically in my practice. And so there's a fatigue severity score. If you get a 36 or higher, you might want to consider looking at getting a sleep study, looking at your airway, because that could be a sleep disorder breathing problem. Why dentists should be concerned? Of course, fix it again. I didn't do it, but this bridge is only less than a year old. He's already breaking all that. So what do you think I'm thinking? Like, wow, do I really want to do that? I mean, you're already breaking all this over here. I had a conversation with him. He was not as receptive, and he did admit he had sleep apnea, but he says, it's gone. I'm cured. And I'm like, I didn't want to argue. So I did actually fix his tooth, but I made him sign a waiver, that he's at risk and it could break again or break his other tooth because of the possible sleep bruxing, not treating his apnea. I think many of you know Glenine Varga from Las Vegas. She's a friend of mine. She helped me put that together, and I use that in my practice to show patients, because a lot of times, again, they don't realize how, as dentists, we can see these signs and symptoms in patients' mouths, you know, the abfractions due to the bruxing, the anterior wear, the tori, the scallop tongue, these arches that are small like that, you know, could some, you know, I strongly believe that with a HealthyStart, if we caught these patients earlier, a lot of that stuff would have been prevented. Another interesting thing, you know, we talk about pulling teeth, and a lot of people are quick to jump to that because of finances, and I understand that. But the thing is that you may want to think twice, because now it's also being considered as an independent risk factor for sleep apnea. And that was from the journal Sleep and Breathing last September. And so anytime you pull one tooth, you have a 2% increase of risk for apnea. And of course, edentulous patients, 61%. If you ever wonder why some denture patients just can't tolerate that thing, you know, maybe consider evaluating their sleep for sleep apnea. Here's one of my patients. I pulled all her teeth. Of course, she had been diagnosed with sleep apnea, was wearing a CPAP, but even so, I removed what teeth she had because of the disease she had, put in an immediate denture, and I often wondered how that affected her AHI. You know, does she sleep with a denture in? Does she take it out? In dental school, we're told take it out, you know, soak it in some cleaner, but the vertical dimensions drop, you know, and of course the tongue goes back, so what do you do, right? So again, just another, that's her CT scan. You can see the deviated septum right there on that lower right side. And then her airways, very small. And of course that's standing, but you know, imagine relaxed in a REM sleep, how relaxed you can get, and that airway closes, can't breathe very well through her nose. And how well is that CPAP working? You know, that's my question. Another patient who wanted her teeth all fixed, and we did. You know, she had all those broken teeth. We did her whole mouth and opened her vertical, but her airway is very small. And again, standing, you can see how small the airway is. But apparently with her, when we opened up the bite, she stopped snoring according to her, and is doing really good. But of course, I haven't validated with that with a study. But what I'm saying is simply is that everything, as Dr. Hendon said, everything we do from dentures to full mouth reconstruction to pedo, it's impacting the airway. And I think as dentists, we gotta own that and really, this is that same patient. She had 3 different sleep studies, walked out of the last one, ripped the mask off in the middle of the titration, the one that we did the full mouth rehab, but she had a severely deviated septum, and nobody had really looked at that until she came to my office, and I sent her to an ENT to help with that problem. Maybe she'll be able to, you know, breathe better. Dr. Levine, I guess Giles Levine, you guys know him, very famous expert on Bruxism, and that's one of his quotes: anytime a dentist sticks something in the mouth to treat Bruxism, you're in for something different, right? You alter the airway. And that, again, is one of my patients who was wearing a lower flat plane occlusal Michigan splint that was given by the previous dentist, and he has severe apnea. And I was just curious. I said, take home this pulse ox, and I said, I just want to see what's going on with the guard in and with the CPAP and without the guard in, just the CPAP alone. And you can see that he basically, with his with the CPAP and with the appliance and the CPAP, he actually did better. His oxygen did drop, but when he took out the appliance, the oxygen dropped significantly. So the CPAP alone wasn't working very well. So again, it just varies from patient to patient. But here we go. I'm going to show you the study that shows that if you just give a guard to a patient just for grinding, they may make them worse. And actually, they may actually have undiagnosed sleep apnea. So I believe that to be true, and that's kind of the clinical thinking right now. But again, it varies. The VDO, vertical dimension, is something that's not 100% how it affects. Again, links between sleep bruxism, sleep disorder breathing, TMD. You know, we talk about the relationship, and you know, right now that there's really not 100% evidence that how it all works together, but we know that it's common with these patients. The gold standard of diagnosis, PSG, or I'm sorry, sleep bruxism is through a PSG. Of course, increasing the vertical dimension. That's for those who are dentists, the height of the teeth intraorally. Without a mandibular protrusion may aggravate obstructive sleep apnea in some patients. Of course, dentists need to be aware of this, and then, of course, further studies need to be done to kind of find out. These are some current clinical thoughts out there. Dr. Preen, he's a doctor here in Houston, dedicates his practice primarily to adult dental sleep medicine, TMD, great guy. That's one of his thoughts about how this works. Sleep disorder breathing, Bruxism, TMD for the adult patients, right? Daytime Bruxism, Dr. Rouse, talking to him, talked about this. Daytime Bruxism, nighttime Bruxism, sleep disorder, breathing, TMD. But really, and this is something that came from that textbook, kind of the recent thinking, it's just a hypothesis, but it's not concluded. So again, the evidence is still not there. You can see the links, and we talk about inflammation, oxidative stress, systemic hyperactivity. And so I think all these factors are important to look at. But again, just another paper validating headaches, daytime sleepiness, and how that all correlates. Now, the ADA, when we talk about TMD, that is in the realm of the dentist. Interestingly, in the 1980s, the orthopedic surgeons stopped really messing with that. I didn't realize that they did. And, but according to this publication, they did. And so, but you know, dentists, we're the primary providers for this, but of course, a lot of us aren't trained with that. And that's, you know, where we need to get more training for that. And we talk about the TMD issues with the little kids and of course the prevention. And again, HealthyStart, I believe, is great to intervene with having patients get into these problems. I don't know if you guys know Dr. Simmons. He's here. He's a neurologist in Houston, trained by Dr. Dimino in Stanford. And that was his quote, TMJ, joint of the airway. And I like that because I came from a physician, and he said physicians need to start looking at teeth, right? So I don't know if you guys have seen this video. I'll show you this real quickly.
Airway and Tmj. The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt. The result is a deformation of the lower arch known as the bicuspid drop-off. The result of this deformation of the upper and lower arches is the presence of premature contacts upon closing, which shift the lower jaw distally off of the physiologic trajectory. The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward. Upon opening, the disc can shift onto the condyle to restore the TMJ's correct position, reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headaches. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backwards. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
So that's just a quick overview of kind of TMJ, airway, and posture, how that can, impact somebody's health. And of course, I see a lot of these patients, and of course, I always think what could have been done to prevent that. And of course, we have an answer, I believe, with HealthyStart. This is a way of thinking of things. When we talk about dentistry, the whole thing with dentistry, we always talk about where we put the teeth, right? Like, let's put the teeth together, let them bite. But kind of the paradigm shift is, how is the patient breathing? What am I about to do that will impact their airway, their TMJ, their punches? Kind of in that order. And of course, these are the 5 tasks that are essential for breathing through the nose. We kind of talked about that yesterday. Humidify the air, warming the air, filtering the air, accelerating the air, and of course, the most important thing of that is producing the nitric oxide that kills the pollutants in the air, so that get that better oxygen through the blood system. I'm going to show you this one case of a female patient that I treated, just to kind of show you where some of the things I'm excited with HealthyStart, how we can prevent some of these things. But this is a 27-year-old female, has ear pain, fatigue, general weakness, migraine, tension, headaches, TMD, clicking on the right side. She had 4 bicuspids extracted. She's clenching, grinding. Her wisdom teeth were removed, had back pain, fibromyalgia, abnormal digestive complaints. And of course, I highlighted the stuff in red because that's kind of related to the somatic syndromes I was showing you earlier. And the list goes on. Dizziness, muscle weakness, tingling, numbness, anxiety, depression, excessive stress, daytime sleepiness, morning headaches, bed partner reports snoring, severe night sweats, and then low vitamin D. And of course, she had an accident that really made this worse. So the point of that is that, of course, these are the medications she's taking. Gabapentin, very popular, given to patients with pain, and then Flexeril for muscle relaxer, Lexapro for anxiety, and Singular for better breathe. The ENT gave her that. But you can see from the profile here where her lower jaw is further back, right? So that is a issue physiologically so how do you deal with that? At this point, she's an adult, you can't do anything like HealthyStart to really grow her. Her growth is done. So, we just kind of, again, begin to manage the problem. And, there's her CT scan and showing her craniofacial development there. And hypertrophy of the lower turbinates, not breathing well through the nose, her TMJs are not aligned well. And again, she had a lot of those symptoms on this. And for years, nobody talked to her about her sleep. She's seen a neurologist, primary care, and they just kept giving her medication until she saw me. And then we kind of looked at I took these pictures. You can see her dentition, her open bite there on the right, where she's having the clicking pain. And interesting with that I've noticed correlation is the turbinates, where his mouth is open. Sometimes that's part of wherever it is, they can't breathe well through their nose, so they try to make space through their mouth to get that air through. And you can see the scalloped tongue, small jaw or big tongue, which one is it? And again, she had 4 bicuspids removed, everything retracted back, and things started getting worse for her. Of course, this was her sleep study results. Of course, the AHI was pretty normal, RDI was 12, oxygen was pretty much 95% throughout the night. So again, that's not an obstructive sleep apnea patient, but more of an upper airway that, as dentists, we can, in collaboration with a physician, help this patient. Those are the plans we had for her, and you can see that the bottom of the list, it's pretty extreme, to break people's jaws moving forward, and that's really, in an adult, the fix for the problem, but it's very expensive and also life-changing, so it could be something patients have to really prepare for. I'm going to kind of skip through some of these stuff quickly. I just wanted to show you kind of where dentistry's been, where it's going, and get to the HealthyStart part here back. Practice guidelines from the AADSM, or American Academy of Dental Sleep Medicine, changed in 2015, talking about snoring, taking that more seriously. And again, they talk about a qualified dentist, you can find that on their website. And then, of course, tech changes that have happened with dentistry, cone beam CT, different appliances, all this stuff, heart rate variability. I think many of you have cone beams. The evolution of appliances, there's over 100 of these things. It seems like every time I go to the meeting, every year there's always a new one coming out, and essentially they do the same thing, but there's really not a lot of studies validating which one's better than another. It's kind of a patient case selection, and the different types that are out there, the hinges, and of course ResMed, I put that up there only because they're the only medical company that's involved with oral appliances. All the other ones that I'm aware of are all dental companies. So that was kind of a game changer in getting the dentist on board with that. Again, I put those dates up there so you can see how recent this stuff is. It doesn't have, and these are just new things out there. I'm not promoting any of this. I'm just kind of showing you all the stuff that's out there that claim to do things, and is it true or not? And of course, there's temporary oral appliances, trackers, and the interesting thing is that you can do all this stuff, but a patient, the literature demonstrates that if somebody can't breathe through their nose, they're not going to be able to tolerate this stuff very well. And again, this is talking about, goes back to working with the kids and identifying some of this stuff. And the Matrix, Dr. Rimmer, met him in Boston, invented that. He actually was the dean of Galveston Medical School here and invented the AutoPAP. And so he invented this to try to get more predictability with oral appliances. And again, case selection, they do that at the sleep lab, and it works pretty well. I've used a couple of those cases. But, combination therapy is another thing. People that are real severe that, and this is all about, and of course something new that's out there is heart rate variability to see, how that affects your sympathetic drive and how you're breathing, sleeping, the position of your bite. Again, I talked about the ADA, how they were finally taking a stance in dentistry back in Denver in 2016. And this was the policy, interestingly, that they printed back in January, but recently they just released that one. I highlighted in yellow, look what they added. And I'm excited about that they've incorporated the kids in here, because there was nothing stated on the first one about children. And so somebody, because they had an open response, and I believe some of the dentists said, hey, wait a minute, what about the kids? and so I think that's critical or game changer for dentistry, our profession, because now that is going to be, moving us forward in this direction. Last year I had the opportunity to attend the Airway Summit, the AAPMD, and this was a good kind of a white flag ceremony. When you surrender, they said, okay, all dentists, put away your clinical dogma, let's get together and let's talk about the airway. Let's see how we can help our patients. And so there was a group of, physicians, ENTs, dental hygienists, myofunctional therapists, physical, the whole gamut. The only people that weren't in the room, interesting, were insurance people. And so, but clinicians from every aspect. And another great book that talks a lot about this stuff, Airway Health, that's Michael Gell, one of the authors of that. And it talks a lot about the stuff, the sleep disorder breathing, the kids and all that. So, and kind of, this is kind of how it's been. We're on our islands. Medicine's over there, dentistry's over here, and finally we got this bridge called dental sleep medicine that has, helped us to try to help our patients. But a lot of that still focuses on the adult patient. And so, what about the kids again? So that's really where, I guess, a passion of mine has come, dealing with the adult patients, to manage them and say, well, how do we, get ahead of this? Again, I mentioned some of the challenges. Lots of dentists out there don't know how to screen or when to refer. Again, this is, I think, why the ADA is stepping up and saying maybe we should start teaching our dentists to recognize this at least. Of course, corporate dentistry is spreading like wildfire, and those of us in private practice, it's a little competitive with that. And then, but does that really fit in their business model? I don't know. We'll see. Medical insurance companies, at least in my area, I haven't been able to get a network very easily, so I don't know if that's true across the United States. And talking to other dentists, I found that to be the case. And again, the other thing is the number of board-certified sleep physicians is decreasing, and that's getting less and less. Maybe something to do with medical reimbursements for sleep studies and all that. And then a lot of the labs aren't adequately set up to diagnose sleep disorder breathing, upper airway, and especially I talked about in kids. And then medical insurance companies sometimes won't pay if you're just a snorer, right? Or upper airway, you got to be more sick, basically. And again, you know, in Texas, if you aren't familiar, there was this big lawsuit, medical board against the dental board, getting more political stuff. Just to kind of make you aware, I'm not sure where that's at currently, but the main point of that is that we as dentists can't diagnose the problem, right? Because that's really a medical condition, and that's fair to the physicians because sleep disorders are huge. I mean, there's a lot of them, and so we got to be careful how we're treating some of them. And you know, I put this. I'm sure you guys remember this clip from this movie, but
Okay, here we go. Patient named Phil Wennick, 2:45 a.m. arrival. Minor concussion, like I said, some bruising, pretty standard. Do you mind if I take a look? I'm actually a doctor. Yeah, you said that several times last night, but really, you're just a dentist. Okay.
so you thought really you're just a dentist, right? So, but physicians are coming around and really trying to work with us. But, you know, there's a lot of stuff out there that also from our part that we gotta respect where we have to cross the line. But here is some quotes from key opinion leaders in the future dentistry will approach and treat the compromised airway as a 24-hour day issue. In the future, dentists will be challenged to shift from one-size-fits-all paradigm to an advanced decision-making process where preventative therapeutic intervention can be concentrated on those who will benefit, sparing expense and side effects of those who will not. And again, Abram Goad, I know that tomorrow, sleep disorder breathing will be recognized as having a pathophysiologic role among disorders where knowledge of its presence is ignored or resisted today. Again, that's the slide I was showing you about. And, you know, personally, of course, we've implemented HealthyStart in our practice, excited about executing this and helping kids on this early spectrum before they get way over there, right? And so as soon as I got certified, my two kids got the habit corrector. You know, they weren't having real severe sleep problems, but my son was getting up out of his bed and always going to my daughter's room and kind of night terrors. And he's in braces, but I put the habit corrector on him, even while he's getting done with that phase 1. And then my daughter finished phase 1, and I'm actually just doing the next appliance to, you know, for like the phase 2 part just to get everything in line. But yeah, so they're wearing those, and you know, I can report that they're doing really well with that now. And then I actually had a sleep study, and it turned out that, and I put myself up there because I actually turned out to have an HI of 5 with an RDI of 7, which puts me up into that medical management. So I wear an oral appliance. You know, I know about this stuff personally. But, you know, so I'm looking, okay, how can I help my kids perhaps to have a chance of, you know, physiologically. And then, you know, I'm going to end with this here, this case. Jill came to my office and helped me get this all going, just like you guys are doing this weekend. And this was one of the patients we screened, and his mom owns a daycare across the street in our neighborhood. And so, as you can see from his eyes, he doesn't look like he's getting very good sleep, right? He's taking 54 milligrams of methylphenidate, which is Ritalin, and for his size, and has diagnosed with ADHD. And so his mom was concerned about that, didn't know that there was a solution out there that could potentially help him. And you know, these are the pictures that I took to submit the case on the portal. And you know, you can see his little, his lower class 2 there, and there's his teeth. He's missing a lower incisor on the bottom there. And still has some primary teeth. There's his tongue, and you can see classic sign that I see with the adult patients. You ever see how adult patients' teeth tilt in like this? And you're like, how did that ever happen? Well, I found an interesting answer to that in that textbook, talking about when somebody's nasally congested like this, like he is, the insult that teeth do is they go like that, making it even less space for the tongue. And, oh yes?
Was he missing the lateral implant?
No, yes, yeah. So, side view here, and I have the pano come in. Let me see. Yeah, there it is. Yeah, he didn't have it there. So yeah, so there's his pano, and you know, the CT scan, you can see his sinuses are pretty clogged up and not breathing well. So he's in the habit corrector, and he was spitting it out a couple times. But of course, from this, I already knew he had an issue up there. Referred him to the ENT that is board certified in sleep medicine, allergy, as an allergist, and an ENT. So that would be the best guy that I sent him to. So him and I are helping this little boy to, and then the other interesting thing you can see here, the posture of his tongue. If you look at it, I even asked the assistant, I said, did you stick the rod back in to take the, because I normally don't, because I want to see where the joints sit normal in a bite. And there was nothing there. He just can't breathe through his nose very well. And so he's a mouth breather. You can see where he's trying to get air even while he's getting the x-ray. And so, but anyways, yeah, I didn't get the picture, and I should have. He was in the office the other day. That darkness under his eyes, since he's been using the habit corrector, I've had him doing it during the day, a couple hours, use it at night when he can. And then of course he's taking some medications for his inflammation of his nose, but already you can see him physiologically, the appearance, and which is great. So this is a favorite author of mine, John Maxwell. It talks about, I challenge you to think of one act of genuine significance in the history of humankind that was performed by a lone human being. No matter what you name, you'll find that a team of people was involved. And of course, HealthyStart has a great team of people to help implement everything that they're trying to promote to help these kids. And that's one of the big passions that I've got now, is just to go out there and do that. Now having the resource, because being on that side of managing the problem, a lot of the parents would ask me, like, well, what can you do for my kids? And really, honestly, I didn't have an answer at the time. And so I was glad to see that the HealthyStart had a booth at the American Academy of Dental Sleep Medicine meeting last year in Denver. That's where I kind of saw the table. And then people that I know started telling me about it, so I looked into it, and it made a lot of sense to implement this, to catch kids early so they can be a better version of themselves. Well, I appreciate the opportunity, and hopefully I shared some things that might spark your interest, curiosity. But I know that by y'all being here, that's great, and I congratulate y'all for taking that step, because that was I don't know how difficult it was for y'all, but I kind of look into things and want to know before I take the plunge, is it worth it? And I can't say I have any regrets with this, because it's a great tool and system to really change the lives of kids and your communities. And then not only that, but really for the patients that we're already treating in a dental practice, especially you being general dentist, if you're treating already adults with sleep disorder breathing, sleep apnea, then as I showed you that study, you're more likely their kids are candidates for this. And so if you catch them early, I'm sure those parents will thank you for the rest of their lives. Yes. So again, thank you, and I appreciate the opportunity.